straightforward, some which are more controversial, so we'll spend a bit more time on those. Before starting, I should mention that we have some exemptions, but 19 don't see many kidneys or don't feel confident to diagnose kidney tumours. Penile as well seems to be more common than the rest. And again, just about 9% answered the questions in this EQA circulation. So we've got, again, a spread from trainees and overseas, but only consultant EQA members should vote, I should say. So AH1, first of all, what we're told, it's a 49-year-old male, 25mm tumour, close to the margins. It was described as a yellow solid tumour, and no immunohistochemistry was provided. So on low power, we have a partial nephrectomy specimen. It's been inked at the cut surgical margin. We have well-defined tumour, which looks as if it's pushing but not invading into the surrounding perinephric fat. Medium power, it looks as if it's encapsulated, and we've got two areas really, perhaps a more solid area and slightly more cystic, perhaps microcystic areas on the right side. And slightly more higher power again, we can see these microcystic areas a little bit better. Some of them look as if they've got papillary structures, and some, even at this power, we can see some cellular material. They look foamy within the cores of these papillae. The more solid areas, there's some closely packed small little tubules again, with foamy macrophages in the center. No areas necrosis on the slide, and again, these foamy macrophages were present in the cores of these papillae, and thin microcystic areas. And when we look slightly higher power, most of the cells had a light eosinophilic cytoplasm, quite reticular in places. All the nuclei were at the base of the cell, near the basement membrane, not at the apical, not at the luminal border, I should say. And that will be important because there's a couple of questions, a couple of answers, I should say, which need addressing. But morphologically, it would do very well for a papillary RCC. So because immunohistochemistry is often used these days, a fair number of people wanted to see more immunohistochemistry or wanted to see the immunohistochemistry. And I've listed the number of comments we had about this case, the 36. So bearing in mind we had over 450 members answer the circulation. This is quite a small number of comments compared to some of the other questions. Some people still using the type 1, type 2 categories, which obviously that's not recommended in the latest WHO classification. Quite a number of those 36 comments wanting more immunohistochemistry, some describing the oncocytic features. And some perhaps didn't appreciate the capsule around the tumour. So it's a fairly straightforward question to start with. Almost 98% favour this was a papillary RCC. But we've got about 15 or so people who've mentioned other things. So thyroid-like follicular variant, I think people were perhaps taken by the rather microcystic areas, perhaps with some colloid within them. It didn't look typical of thyroid colloid, I've got to say. This is an emerging entity. It's not recognized as a proper entity in the WHO classification. It doesn't tend to have papillary structures, and it doesn't have those foamy macrophages as well. The ESC, so the eosinophilic solid and cystic, again, mainly unencapsulated tumours. They can have obviously solid and cystic areas, or predominant of either type. And the cytoplasm is quite voluminous with those basophilic stippling, the leishmaniasis type appearance, which didn't appear to be present in this case. Clear cell papillary renal cell tumour, I should say. I didn't think it looked like that. The didn't look very clear cell, and the nuclei were at the basal part of the cell. And the other three didn't, well, the other two, I should say, didn't look. The oncocytic papillary, so one person has included in that. In the 2016 classification, oncocytic papillary was described in the papillary chapter, but it's fallen out of favour in the latest WHO classification. There is an entity with that reverse polarity, but it's not typically called oncocytic papillary, but it's in the papillary category, and it might be worth to be generous in marking that one, but probably 1 scores 1 and then the rest 2 to 6 score 0, and I would say to be generous with question number 7. So hopefully this is the first Slido slide, and it just says it's scoreable. First of all, that's all. And again, I think it is scoreable, so we should have a fair number of responses. Shall I finish at around 100, John? Is that acceptable?
I think it's obvious scoring, and you've got a high
Yeah.
percentage, you can cut it off much quicker than that. But
Fair enough.
for the scoring, I would wait for it to get to at least 2/3 of the people to score. You've got 175 people, so 100 for the scoring, but this simple question,
Yeah.
I wouldn't wait.
Okay. So let's score. Yeah. So most people. So shall we start off with the scoring first of all? So right. Okay. So AH1 scoring. So you should on your phones be able to see the actual scoring. So please click away. Happy to crack on, John? 103.
Yep.
Yep. Okay, so renal papillary RCC, so 1 scores, so that's fair enough. 0 for the thyroid-like follicular, 0 for ESC. Clear cell papillary, yep, 0. Clear cell, 0. Tubular cystic, 0. And oncocytic papillary, 44. Oh, let me just go back. Apologies for that. Let me just go through that once more. So 0.5 dead heat. I think we'll be generous, 0.5. This next question is a little bit of a tricky one. We won't be scoring AH2, and I'll explain why as we go through the slides. It'll be an interesting educational case anyway, but there's been an issue with this case. So what we're told is this is an 85-year-old female, the bladder tumor. There is a history of a kidney tumor as well, which I'll go into as we go through the slides. And these are bladder chippings. Again, we're given some immunohistochemistry information, CK7, PAX8 positive, the rest are negative, P63, GATA3, chromogranin. So on the low power, multiple fragments of a tumor. Some fragments appear quite cellular, others quite degenerate, quite hemorrhagic in places. And as we go on medium power, we can see these areas of perhaps closely packed areas of what look fairly clear or likely eosinophilic cells with a very rich vascular network running throughout. And slightly higher power again, we begin to see most of them do appear clear. There is a reasonable cell border around. They're quite easily seen. I wouldn't say they were very prominent, but they're easily seen. Again, we appreciate the very rich vascular supply throughout the tumor. The nuclei, there is nuclear polymorphism, mitotic activity, and some cells do show binucleation, and some very bizarre looking multinucleated cells. Personally, I have favoured more of a clear cell morphology for this one rather than a chromophore, but I can see from the immuno why people have gone down certain paths. So a lot of comments on this case compared to the previous case. So 87 requiring much more immunohistochemistry, seeking further opinion. A fair few didn't think it was suitable, again, based on the morphology and the immuno. So again, 36 comments in the last question, 267 comments here, and many, again, trying to weigh up the pros and cons of the morphology, the immuno, and and the history as well, the previous renal tumor. So some comments very confident this was a metastatic chromophore, some confident it was metastatic clear cell, and then a fair number, approximately 70 people, not favouring this was a metastatic renal cell tumor, favouring a primary clear cell adenocarcinoma of the bladder, again, and giving various immuno reasons and morphology reasons. Again, lots of comments about how much CK7 positivity is in clear cell RCCs, sort of a small number in my experience. I'm sure we've got some gynae pathologists also doing the urology EQA, because a lot of gynae focused opinions as well about what this could be and what similarities to the tumors that they see in the gynae specimens. And again, some very long comments, and we do read every comment. That's the thing. So 267, we have to go through and then pick out certain comments and do a bit of reading about it. So it takes quite a long time, the certain questions. And some clearly didn't think this was appropriate for EQA, and it's not appropriate for this EQA. And the reason for that is that one of these diagnostic categories, so number 2, so the renal cell carcinoma chromophore, was added in error after the circulation had opened. So we obviously need to do a bit more digging to find out why that happened. So clearly, if a question or a diagnostic category has been added after the circulation's been opened, some people have answered the EQA and not seen this diagnostic category, so we can't score it. So metastatic tumor was the commonest, and a lot of those comments referred to obviously the history, the immuno, the morphology. People have then seen this category, which shouldn't be there, and almost 24% have gone for metastatic chromophore. But a fair number, 70 odd people, have commented on clear cell adenocarcinoma of the urinary tract. Now, my experience with that is limited. It is a rare. I've seen cases where it's mainly in the urethra, isn't it? There's a superficial biopsy, and differential is on this top right screen is with a nephrogenic adenoma. But deeper down, obviously, they're a lot more pleomorphic and infiltrative and clear cell morphology. So I've never seen it in the bladder, but it tends to be the urethra. But again, we can't score this one because it's sort of administrative error more than anything.
So there were some questions asking about, can we not score it combining RCC, chromophobe, and metastatic tumor because it was added late probably?
It's not really fair. It's not fair because some people have obviously not seen a particular diagnosis. So we can't really do it. It would score obviously on 1 and 2, but it's not fair, I should imagine. Are you happy with that?
And then there was one other comment about someone has seen similar case in the department, and there was, you do see similar morphology in clear cell adenocarcinoma, and I've seen few cases in the bladder, so we cannot differentiate without more markers.
That's fair enough. I think it would have been a difficult one to score had we not had that
Yeah.
problem. So yeah.
So there was one question which was type late for the previous one. Type 1 and type 2 behave differently, papillary. Why are we not differentiating this?
I think most type 2 papillaries have now been shown to be something else, really. Isn't that why the WHO, when you do molecular markers, the type 2s aren't associated with a c-Met proto-oncogene. So I think the reason is type 2 often tend to be another RCC category. So I think that's why they've merged it and just call it papillary RCC. I think that's my understanding anyway. Okay. So it's a little bit of a shame, that question, because it was quite an interesting, but more of an educational case. I have contacted the pathologist who submitted it, and I think the original kidney tumor was a chromophobe, just out of interest. So AH3.
Sorry, Hugh. I think we need to emphasize that people, if the diagnosis is not on the list,
Yeah,
and you want to put a diagnosis in, you mustn't be contacting the EQA secretary to ask
yeah,
for the diagnosis to be added. So you just use the other category and then put it in the comments rather
yeah.
than trying to get the diagnosis added, which occurred in this case. So it's a learning point from everyone to use the other category if they must, but the diagnosis should be there. And in the 16 years that we've been doing this, we've only missed a diagnosis once, as Professor Burney is regularly reminding us of. So please use the other. Do not try and get the diagnosis added.
Thanks, John. Great. So AH3, hopefully this will be a bit more straightforward. 64-year-old male. It was a left renal tumor with some lymph node enlargement. Quite a large tumor, 14 centimeters in diameter, and centered on the hilum with vascular invasion. And we were given a small panel, and that's related to some of the comments that have been included, just a cytokeratin and a desmin. So we've got a low power image, well-defined tumor, some cellular areas, perhaps a bit more of a edematous area in the center with clear evidence, even at low power, of necrosis at the right side of the screen. Medium power, interlacing fascicles, some perpendicular to the plane of section, some parallel. And when we do zoom up, it was clearly a spindle cell population, varying degrees of pleomorphism, but mitosis very common, very easy to find mitotic figures. No evidence I could see of any epithelial, as in a clear evidence of any clear cell component or any glandular component. So this is just a shot then of the quite easy to find areas of necrosis. Now, A1, A3 appeared negative. This is a shot of a desmin, which is very strong, diffuse, strong staining. So a lot of the comments were centered around the fact that we didn't have much in the way of immunohistochemical stains, and that's a fair comment. Many seeking further opinion. Again, we are uropathologists, so in a case like this, we would show it to a colleague, obviously with soft tissue expertise. And again, I haven't counted the total number, but it was a fair number of comments saying that we are urological pathologists. I would show it to my soft tissue colleague and do some more immunohistochemical stains, and that's a fair reflection. Excluding melanoma, melanoma markers to exclude leiomyoma, angiomyolipoma. It was very mitotically active, got to say, and there was no evidence of any fat within. Some people had gone for a usual type angiomyolipoma, but again, it's a fairly good concordance, almost 98% going for leiomyosarcoma. Again, it did show malignant type features on morphology that was very mitotically active, I thought, and areas of pleomorphism, perhaps not gross pleomorphism, but necrosis as well, which perhaps would argue against leiomyoma. For rhabdomyosarcoma, I did ask don't have many soft tissue pathologists on site, but we do have some friendly pediatric pathologists who are more in tune and looking at rhabdomyosarcomas, and it didn't look like a rhabdomyosarcoma, no, not a cellular blue round blue cell tumor. No rhabdomyoblasts. The other category, I think we should be quite lenient here, just commented on sarcoma. I would do further immunohistochemistry, not being perhaps more detailed than that, but that's a fair comment, and I perhaps would view that leniently, because that's probably what we would do in practice. We were given the desmin and the A1A3, but in practice we would do a lot more. So 1 obviously scores 1. I would probably say 0, 0, 0. And then the last one, I would probably say to be as lenient as possible. So let's see if this works. I think it is scoreable. It's got a high concordance. So 56. I think I'll move on. I think it is scoreable. Yep. Okay. And then if we go in, then if you go on your phones and then go to the individual diagnoses. So we've got 78. I'll just wait. Hopefully we can get up to 100. Yeah, I'll stop the scoring now. I think we've reached a point. So leiomyosarcoma scores 1. AML 0. Leiomyoma 0. Rhabdomyosarcoma is 0. And let's see. Yeah, so 0.5 then for the sarcoma. Please do some more immunohistochemistry. Okay, all right. Again, first testicular case. 33-year-old male, that's quite important. So middle-aged chap, 44 millimeter grey looking tumor in the orchidectomy specimen. And we were given some markers. So SAL4 was positive, OCT34, PLAP negative. And low power, we've got a well-defined tumor, partly encapsulated, with a rim then of background testis. And even at low power, there's some slightly different areas of the tumor, perhaps a more cellular area and a more edematous looking area with some tumor cells within it. On high power, I haven't got many images of this case, but the more edematous areas had sort of stromal edema with these pseudoglandular-like spaces and some small nests floating within them. And then the cellular areas, again, more densely packed nests with very little intervening stroma. It doesn't look, even at this low power, there's not a feeling that there's a lymphocytic infiltrate running through the tumor. And high power, probably make the diagnosis. Again, some of the comments did mention the quality of the slide, the quality of the image, and it's not the scanner, I think. We had the original slides to look at. It was just perhaps a thickish slide, thickish section, I think, because the looking down the microscope, it wasn't looking great. But I think it's fair enough to make a diagnosis on. These are intermediate size cells with fairly open looking chromatin and also lots of small cells with a high NC ratio and quite dark looking nuclei, and then scattered around some very large, so the large giant-like cells with some prominent nucleoli. Again, not much in the way of lymphocytes at all. The background seminiferous tubules, again, did not show any GCNIS. I've had a good look around. I couldn't convince myself. So not a huge amount of comments on this case. I think most people were happy. More immunohistochemistry again, more blocks. We did have comments, quite a few comments in the 25 of the age, and this is taken from the WHO Blue Book. Certainly, a lot of us think, oh, somatocytic seminoma tends to happen later in life, but there's quite a wide range acceptable, and it is commonest in the 6th decade of life. But this guy was 33, and so it can happen. More immunos. Quality of the scan slide is poor. That's fair enough. It wasn't the scanning issue itself. Some people didn't think that SAL4 was positive in this tumor, which is not correct. And again, a fair number gone for yolk sac, perhaps, I don't know, perhaps influenced by those edematous areas and those pseudoglandular areas, but perhaps also by the age as well. So these were the diagnostic categories. So most people going for somatocytic tumor, which I think is the correct diagnosis, that would score 1. But I think there's about 20, 25 people thinking it was something else. So post-pubertal type, again, the more edematous areas perhaps may have led people down that diagnosis. Pre-pubertal type, I think that's restricted to under 10s or the first decade of life, my understanding. And seminoma didn't really look like that. So I'd probably say 1 is 1, score of 1, and then the rest are 0. I think the first question is, it does look as if it's scoreable, I have to say. So we've got 84, yep, I'll crack on. So the first one, then if you go back to your phones and then go through the diagnostic categories and score those. So we'll just wait for 100 and then. Okay, right. Don't think many other people are. Okay. So somatocytic tumor scores 1. Yeah, yolk sac is 0. Prepubertal type would be 0. And seminoma is also 0. Yep, okay, that's fair enough. Good. Any questions before we head on to the next one?
Yeah, so someone says if we have greater than 90% consents, do we need to check whether it's scoreable or should we just directly score it?
Well, so going through the motions really, it probably is wise for us in our first EQA just to go through the motions. I agree it's 95%, but it's just to give everyone a chance to say their views. Okay, so next one is perhaps an educational side to this case as well as an EQA case. So this is an 81-year-old male, new diagnosis, solid bladder tumor with a 2RBT specimen, and we're given the actual images of several markers as well. And there's a supplementary question as well. So what we have is quite an interesting case. We have multiple fragments of a cellular tumor, and most of the fragments appear similar, but there are some areas, and we'll come back to there's a central papillary section in the center, but we'll come back to that. Most of the other fragments had a similar looking appearance, so quite an infiltrative, dark looking tumor with, as we go on to high power, cells with very high NC ratio, quite dark nuclei, granular cytoplasm. So it did look like a neuroendocrine carcinoma, neuroendocrine small cell carcinoma. So lots of apoptotic bodies and areas of necrosis elsewhere. So that was probably more than 95% of the tumor, I would say, probably more than that. But then tucked away in that central area was something that did look different. So a papillary proliferation, nice fibrovascular cause, looked high grade, but very small in number and looked completely different then to the neuroendocrine carcinoma. So the immunohistochemistry seemed to support this. So all the chips that we thought was neuroendocrine carcinoma did stain nicely for CD56. The papillary urothelial carcinoma was negative. And then so for the synaptophysin, same result. And then GATA3 shows the opposite. So it picks out the urothelial carcinoma very nicely and is negative in the in the neuroendocrine carcinoma. High power shot showing the same thing. And again, almost complete negativity in the neuroendocrine carcinoma. And again, from the comments and looking through the tumor, there were areas of squamous differentiation as well, nestled in amongst the neuroendocrine bits. So got lots of necrosis at the top left here, sheets of infiltrative neuroendocrine, and then small squamous looking areas. And then also, perhaps not the best picture, but there were areas of muscle, detrusor muscle in this, and it did look as if the neuroendocrine carcinoma was infiltrating through the muscularis propria. Can you still hear me, Lopa? It says connection lost on my end.
I can hear you.
Ah, perfect. Good. Not speaking to myself.
No.
So further blocks, seek further opinion, and not suitable for EQ waiver. And we did get a fair number of comments on this one, mainly relating to nomenclature issues. So most people in their comments said that this is a small cell carcinoma or neuroendocrine carcinoma, but there's other features in there as well. Some were saying this is a urothelial carcinoma with neuroendocrine, but the vast majority was small cell / neuroendocrine carcinoma with a tiny amount of urothelial and squamous differentiation. But how do you comment that in the drop-down box? There wasn't a specific category. A lot were saying about the latest WHO classification. I've got a little slide to show that. Many saying report as a small cell neuroendocrine carcinoma and give the exact percentages, which is a very common sense way of doing things. Some people sticking rigidly, this is a urothelial carcinoma with small cell differentiation. But we've got a split in the drop-down list of how people have voted, but essentially everyone's saying the same thing. So the people who've clicked 2, 3, 4, and 6 have all said that this is a neuroendocrine carcinoma or small cell, large cell, but there is also other features of urothelial carcinoma as well. And really, for practical purposes, the small cell is the most important feature, for treatment. But the drop-down list that we do have, maybe we need to have a look at that to see if this will score a little bit better. But I would suggest that 1, 2, 3, 4, and 6 should be merged. Number 5 doesn't mention anything about small cell. So in that respect, it doesn't sort of, I would think that would score 0. But, you may feel if you want to be lenient, we'll see. Right. Okay, let's see.
Just a comment here that neither CD56 or synaptophysin are totally diagnostic of neuroendocrine origin. INSM1 and chromogranin are more specific. CD56 should not be used anymore for this purpose.
Fair enough. it did look like neuroendocrine morphology, to be fair, and yeah, I think a lot of people would have called it without doing the immuno, but it does look as if it's quite a nice differentiation anyway.
And then again, an exception to this rule is small cell neuroendocrine carcinoma. The presence of this component would guide patient management. So a tumor with any small cell carcinoma component should be reported as small cell neuroendocrine carcinoma with estimated percentage of other components, if any. For example, a tumor that shows 20% small cell, 60% urothelial, and 20% squamous differentiation would be reported as small cell carcinoma, like 20% small cell, 60 urothelial, and 20 squamous.
Yeah, that's fair enough. No, thanks for that. So, and again, that echoes what's happening in the latest WHO classification. So they're given their own chapter, and within that chapter, it talks about mixed neuroendocrine neoplasms. So we may look to adopt that in a drop-down box. We'll have a think about that, and commenting on the various types of tumor differentiation, which are the second or third component. So. Good. Okay, so is it scoreable? I think it is if we combine 1, 2, 3, 4, and 6.
Okay. Some more thing. Management will be determined by large neuroendocrine component. Neuroendocrine large cell carcinoma is incorrect without mention of small cell.
I think we should still stick it. I think people should be as lenient as possible. But that's probably beyond my level of expertise to know about the large cell neuroendocrine. So I got 99. Yeah. Is it scoreable? Yes. So let's go back then to your phones or your other computers. So let's wait for a fair number. Obviously, you're only seeing 0, 0.25, and 0.5 in your scores, simply because there's a supplementary question coming up. Okay, let's crack on. So it's down 5 for that. So neuroendocrine carcinoma 0.5. Neuroendocrine carcinoma 0.5. Again, large cell, okay, 0.5. Urothelial, yeah, with squamous differentiation, we'll put that as 0. And then final one, 0.5, yeah. And only one person had put that comment, but I think that's equally correct.
Okay, so we have one more comment on this question. Actually, do the oncologists not have specific chemo for small cells? So if small cells not mentioned, it alters treatment.
That's right. So we marked down the ones that didn't mention small cell. Yeah.
And then that this is not large cell neuroendocrine carcinoma.
Okay. I'll ignore the large cell for the time being. So, but I will get back to them about that. I will find out from my colleagues in oncology. So we did see the tumor invading into the muscle, so morphology. So again, there's a supplementary question about staging. Neuroendocrine carcinomas / plus or minus urothelial are still staged according to normal urothelial carcinoma staging criteria. So most people quite correctly using T2, but a reasonable number didn't see perhaps the invasion of the muscle. So 13, 9, and 4 thinking it was something else. So first of all, is it scoreable? I think it is. So it'd be 1 for the T2 and then 0 probably for everything else. Okay, so we can, yep, so it is scoreable. And you go back then to your phones and you can score each individual staging. So again, it's 0, 0.25 and 0.5 because of the two parts of this question. I think if we can reach 100, I'll just finish it. Okay, right. So not applicable, it's 0. T1 is 0. 0.5 obviously is the correct answer for T2. And then T3, 92% was 0. Okay.
Someone mentioned that muscle invasion makes no difference in this case. And CD56, they find it's a very good marker for lung, and chromogranin doesn't stain much. And small cell carcinoma of urinary bladder is not treated like small cell carcinoma of lung, although it implies poor prognosis and aggressiveness.
Yeah, I suppose the question was about staging that particular slide, but no, this is so the next one is quite an interesting case. The second supplementary question is an interesting one. So what we're told is this is a 65-year-old male who presents with hematuria and anemia, and we have a 30 millimeter, so quite a small tumor in the kidney. Soft and brown, described macroscopically, and we're given then a small panel of markers. So c-KIT is positive, CK7 is positive, and PAX8 and the rest are negative. And low power, it's a well-defined tumor, possibly an area of small capsule at the top, but mainly it looks as if it's unencapsulated. Looks as if it's fairly solid with possibly some sort of looser areas in the center. Now we start to go up to medium power. We can still see this solid, this nested area, and it does have some vascularity, but not, I would say, not to the same degree as the question AH2. And again, they look sort of lightly eosinophilic. Again, the cell borders seem to stand out a lot more in this case. Cell membranes are very, very prominent. The nuclei vary in size and shape. We've got some small ones and sort of pronated looking ones as well. And a perinuclear halo in quite a few of them as well. So some binucleation. So some binucleation at the top here, the 12 o'clock area, and a perinuclear halo. So the cytoplasm also has that sort of fine reticular appearance as well. So it looked morphologically like a chromophore to me, RCC. Some requesting more immunohistochemistry as part of the panel. Some quite confident in the fact that this is the eosinophilic variant. It would probably need to be a little bit more eosinophilic than that to be that variant. Some wanting to see the extent of the CK7 staining. And again, a few people using the term low-grade oncocytic tumor, which again, I'll come on to that in a second. So the diagnostic part of this shows very good concordance. So 98.7% showing chromophore. Oncocytic renal neoplasm, I think that's more a diagnosis on biopsy as a sort of holding category more than anything. And then some favoring it was an oncocytoma. 2 or 3 people thought it was oncocytoma, but it did look like a chromophore and matched the immunoprofile. So I think from a scoring point of view, chromophore would score 1. I think oncocytic renal neoplasm, again, the college prefer that for a biopsy diagnosis rather than a resection. So that would probably be 0, and the 3 would be 0, I would say. So is it scoreable? Looks as if it is. Okay, so Fairfield, I'll stop that at 92. I think it is scoreable. So yes, so 99%. And then again, if you go back then to your phones, and then you've got the individual diagnoses. So again, it's 0, 0.25 and 0.5 because of the supplementary. And I'll just wait till 100 for this one. Okay, so renal cell carcinoma chromophobe scores 0.5. Oncocytic renal neoplasm scores 0. And oncocytoma is 0 as well. That was fairly straightforward. The interesting comments regarding the grading. So the supplementary question was, please grade this according to the ISIP/WHO classification. And many, well, 18, not a huge amount, but those were commenting that it's not recommended. That category is not recommended for chromophobe RCC grading. Some convinced it was a trick question. No, we didn't put this as a trick question. I think it's a fair enough question because we see these in our day-to-day practice. Many using the old classification. So again, not total concordance in this case. So 89% didn't think it was applicable. That's probably the correct answer. Well, that is the correct answer. And then about just shy of 50 people still wanting to grade a chromophobe RCC. So I would say 1 scores 1, and then 2, 3, and 4 scores 0. And just before we do score, I've just got a little table which highlights, this is in the WHO classification book, certain subtypes that are the grading systems validated, so clear cell and papillary, some tumors that it's not applicable to, so chromophobe and TFE3 rearranged tumors, and then other categories then that it may be useful. Some tumors clearly high grade from the start, such as collecting duct and medullary, and then some other tumors that it could actually be misleading. So some tumors that have got a difference in their morphological appearance to the actual behavior. So that's quite an interesting little table from the WHO book. So first of all, is it scoreable? I think it is. I'll stop that. I think it is scoreable, so 98%, yeah. And then if you go back to your phones, then you should have the categories there. So again, it's 0, 0.25, and 0.5. Yeah, let's see if we can hit 100 and then I'll stop then. I think I'll stop. People have had enough. So not applicable by far and away the commonest one. So 0.5. Grade 1, 0. Grade 2, 0. And grade 3, again, 0. And before we go on to the questions, so I've got 2 papers that, if people are interested, they can go and there are 2 papers out there that have described grading systems for chromophobe. The Panna paper from 2010 describes a 3-tier system of grading chromophobes where the pleomorphism is discounted, but it's the sort of more related to the concentration or the nucleic crowd.
Have we lost your voice? Hello? Okay, so there's some electricity cut off in Cardiff. Anyway, Havels at the end of it. There were some comments who does Hales colored iron. No, we don't do it here. Then we have, when we have a grading system as being told, should we actually score this grading? The other thing. The previous question still had some bit of there was a helpful comment that INS-M1 is the most specific one. And the bladder, the small cell carcinoma, not applicable should be right, but most of the time it presents as PT2 and it's staged as PT2. So it should be PT2 rather than not applicable is what I think. So should we start off with case? I think Havel should be back probably. He must be because of his power cut. Probably it's at the right time. It's probably coming to my case. So this is Penway Fen hike in Wales. It's like an upward task for us probably. I suppose everyone can see the screen well. So the case number 7, we are told that it's an 89-year-old female, bladder biopsy, previous TCC in 2014 and 17. We are not provided with any immunohistochemistry. And this was a low power view of the bladder biopsies where we can see a lot of fragments which are actually very full with some cells. Probably a small fragment where you have a loose connective tissue in the lamina propria, which normally it should be. Then we have some rounded bundle of muscle. Going closer to the normal bit area first, largely denuded surface urothelium, and where present, it appears non-dysplastic. Going more close to the lesional areas, we have sheets of macrophages and some inflammatory infiltrate. Closer view on that, we can see that macrophages have bland nuclei, eosinophilic cytoplasm. We also have a lot of plasma cells. Maybe the plasma cells, they look normal with perinuclear half. There are lymphocytes and granulocytes also in the background. Bit more closer look on the cytoplasm. We can see there is some cytoplasmic inclusions with central dots. More of those central dots and inclusions. Just a bit of foreshadowing here. When we look at the capillaries, we can see the red blood cells are disc-shaped or biconcave. I know what you are thinking. You're in the right track. Just a shot from the Oxford website also, showing the Michaelis-Guttman bodies, so that if one has used Leeds or Oxford site, those inclusions were there in both the sites. Comment-wise, we had some immunohistochemistry requests. Other than that, not much. Among the selected written comments, most frequent and repeated one was von Cosa for to highlight Michaelis Goodman bodies. Some also suggested doing pearls and PASTI. Among the immunohistochemistry requests, CD68 was the most common one to confirm the presence of histiocytes. The others were cytokeratin and plasma cell markers to rule out malignancies. Some people thought dissection was too thick, and digital images are not a good way to look at inflammatory or lymphocytic, any other pathology like that. And Michaelis Goodman body can be difficult to see. So with that comments, when we go to the original diagnosis, there must be some problem with typographical thing. That's why we have an original diagnosis of undifferentiated PIN. It's not undifferentiated PIN, as majority of us, 99% of us thought it was malakoplakia. The other options offered were granular metacystitis after BCG therapy. Couldn't see proper granulomas. Plasmacytoma, they were plasma cells, but they didn't look abnormal. Other option mentioned about inflammatory process with numerous histiocytoid cells. They were describing the lesion well, but have missed Michaelis Goodman body. Maybe we can be a bit generous. I hope so. Then we have post-operative spindle cell nodule. I couldn't see anything spindling out there. Granular cell tumor. Can see why people thought it's granular cell tumor, but they don't look properly like granular cell tumor. They had more inflammation. Normally granular cell tumor are ovoid or spindle with fibrocollagenous bands, less inflammation, and of course Michaelis Goodman body helps to differentiate. So first of all, should we go for if it's scoreable? I'll also go and score. Should I wait till 100? Maybe. Howell was doing that.
I wouldn't bother with 96%.
Okay, fine. Great. So everyone thinks it's scoreable. Can we go back to our pads? Okay, maybe malakoplakia 1. I'm noting down these. If you think I'm just looking down, it's just because I'm just, if there's any more hiccups, we have the numbers with us. That's cool. Inflammatory histiocytes 0.5 at least. 0. Granular cell tumor 0. Great. So if we go to the next one, which is a 60-year-old man, enlarged left testis. We are told he had no trips abroad. So enlarged left testis with tan cut surface and gray mottled areas. We are provided some immunohistochemistry this time. OCT34, PLAP, and MNF116 are negative. ZN and PASTI are also negative. If you are asking any questions, can you ask questions in Slido? Because I have a Slido open here. Can't.
No, there are no questions on. Just a comment saying digital was fine for this.
Okay, great. Thank you, Uropa. So we have a testis view with some rete testis here. Some looser tissue here, probably atrophic changes, and the lower bottom looks mostly granular with some pink nodules and some blue cells, probably some lymphocytes. Go a bit higher power. So we have multiple granulomas with epithelial histiocytes, multinuclear giant cells, thin rim of lymphocytes, not necrotizing. They were extending into the rete testis, beyond. The background was largely atrophic. There was no spermatogenesis seen, only some Sertoli cells probably there. Not much comments, some further blocks and levels. Among the written comments, people were describing the lesion, and a lot of us wanted to do further cultures or something more for other infectious process to rule out. There were people who wanted to do further blocks so that we're not missing any seminoma. Sarcoidosis was a frequent flyer, asking for clinical or ACE levels, ACE levels, and further workup for that. There were questions whether there was any intravesical BCG therapy before, and burnt out schistosomiasis also appeared once. Someone thought maybe there would be multiple options which would be valid in this case. So we had again 99%. So we are doing really good. Non-specific granulomatous orchitis got 99%. Necrotizing granulomatous inflammation. There was no necrosis, but can be a bit generous, you know. Sperm granuloma, and vascitis nodosa. Couldn't see any spermatogenesis only, and not very sure whether I can justify these. Normally it happens after some trauma or vasectomy around in the vas or epididymis area, very rarely in the testis. Please be aware that the other should be marked similar to case number 1 because other mentioned sarcoidosis versus non-specific granulomatous orchitis. With that, do we think as a group that this is scoreable? I'll also go and tap down my mobile. Okay. Good. Everyone thinks so. We'll go back and start doing something while I keep my mouth shut. Okay. So non-specific granulomatous orchitis get a 1. Necrotizing granulomatous inflammation 0.5. Then sperm granuloma 0. Granuloma 0. Other 1. Oh, thank you. It's wonderful. So next case, case number 9. Oh, that's the most interesting case probably. 42-year-old man, African origin, presenting with hematuria. And on imaging, he also has metastatic disease. So we know it's quite aggressive and gone out. Right nephrectomy, measuring 100 mm, invasion of renal sinus pad. So all these things are quite aggressive. Immunohistochemistry, I'm sure they were trying to help us. A positivity for Paxate would mean it's kidney, thyroid, or Mullerian, but this is a man, so we thinking of probably primary here. CK7 positive, I'm thinking it's not clear cell. Y-maintain positive, it's not chromophobe. I was just thinking if it is justifying the submitter a bit. That there were some helpful clues in the immunohistochemistry provided. Focal OCT3/4 positivity, there's only one tumor in the kidney, which probably shows OCT3/4 positivity. Tumor cells are negative for CK20 and GATA3 and racemase. Okay, so when we look at the slides provided, we have a bit of normal kidney here, and then we have infiltrating tumor. Going a bit more higher, you can see the tumor is solid, microcystic, in tubular arrangement, some single cells infiltrating between the gloms and tubules, and as a desmoplastic stroma. So individually, the tumor cells are quite enlarged with pleomorphic nuclei, high nucleocytoplasmic ratio, prominent nucleoli, irregular nuclear membranes. What do we have here? The red blood cells, they look very much like sickles. Some of the extravasated red blood cells also look quite sickled. Again, another view where to show that there were a lot of sickle cells in the background capillaries. Not just that, even in the background kidney, the peritubular capillaries and the gloms, there were a lot of sickle cells present. So really a very beautiful case, I suppose, submitted by the submitting pathologist. Understandably, people wanted more immunohistochemistry. That's very true. And further opinion, it's not suitable for EQA, where the other comments. And among the written comments, there were many. And actually, luckily, a lot of them were quite encouraging. People were so happy seeing the sickle cells that they had some really nice comments and excitement they shared when they saw the sickle cells. People have also described the lesion well and mentioned about the differential diagnosis, which is possible, not just MARC-B1 deficient, but vinculin, ALK fusion, FH deficient, collecting duct carcinoma, and also pointed out sickle cell with sickle cell disease, not just MARC-B1, but we also have vinculin ALK fusion carcinoma as the differential diagnosis. Though vinculin ALK fusion carcinoma are predominantly noted in children, yet maybe we'll have more case reports. But everyone is of the opinion you need further molecular testing, and INI1 is more important to for making a final diagnosis. So that was repeated comments throughout. And then neither the essential or desirable WHO criteria is given in the history, although not mentioned. So they people also question whether every information was provided to them, and probably this is not suitable for EQA because of that. And the immuno was not specific. Any high-grade renal cell carcinoma is also a possibility. So maybe when reading these comments, we can be more generous when we see the options, which we as a group have submitted. Even with all the grievances, I suppose if we think we combine 1 and 2, renal medullary and SMARC medullary like renal carcinoma, we reach up to 91%. So we are in our 90s all the time. Collecting the carcinoma morphologically, it's difficult to differentiate. It's more like a diagnosis of exclusion. So maybe we can be generous there too. Renal cell carcinoma, sarcomatoid, you can see my sarcomatoid features. ALK rearrange, we'll assume that people are talking about vinculin ALK fusion 1 and merge it with 1 and 2. I hope that should be fine. Metastatic tumors, sometimes I feel it's like a wastebasket. People just put it there. Can't argue, but there were enough pointers to sway us from there. Then we have mixed epithelial and stromal tumor and mucinous tubular and spindle cell carcinoma. I know these are EQ favorites. They happen so frequently. Maybe people submit these frequently to us to put those in. So I don't know whether people have looked at this or just press the button, thinking that this might appear. Renal cell carcinoma papillary, again, morphologically might be a bit challenging because, and it's been phased out, the type 2 one. There might be something else, but maybe we can be generous there too. Renal cell carcinoma, NOS, again, morphologically possible. Renal cell carcinoma, FH deficient, again, morphologically very possible. And the secondary diagnosis, people again saw sickle cell anemia disease and the same things. Just a cutoff from the WHO classification online, just to highlight that OCT34 is positive in this and not really positive in any other carcinomas in the kidney, but only 50% positivity. And the potential diagnostic pitfall is metastatic germ cell tumor. The other differential in children would be ALK, VCL ALK fusion, while in the adults, it's high-grade urothelial and collecting duct carcinoma. You have no hemoglobinopathies found, then it's called SMARC medullary-like feature. So keeping all this in mind and promising to be generous, let's get back to our scoring pads. All right. So most of us think it's scoreable. So should we start some scoring? We have renal medullary spark deficient as 1, deficient like 1, wonderful, collecting duct. Oh, maybe we're less than generous here. Very strict. Sarcomatoid, okay. 0, bulk rearranged. Is that mean, John? Or they're thinking it's just adult, so Vinsulin ALK is not mattering here. Okay. Metastatic tumor 0, mixed epithelial stromal tumor 0, mucinous tubular 0, papillary 0, NOS 0, femoral 0. Yeah. How very tough cookies we are. So we, just a good article by Chen about the update on selected high-grade renal cell carcinoma, so that she's just talking about doing more work on previously called type 2 papillary carcinomas and collecting the carcinomas and to stratify them. It's a recent March 2024's paper, if anyone's interested. Going on to case number 10, we have a 38-year-old man, and we are told that tumor markers are normal, and there's a 10 mm lesion in the inferior aspect of the testis. Immunohistochemistry wise, we are given some very useful immunohistochemistry. We are told AU13, calretinin, WT1, D240 are positive, and OCT4 is negative. I'm sure at this point, most of us knew what it is, and probably think we just went into the type 1 diagnostic reasoning and just put the answer. But it's quite interesting. I thought this was the most interesting case, actually. Part of the testis with a lesion here. The background testis doesn't look very healthy. If you look at it's a lot of spaces, more like atrophic change. Even among the lumen, it looks more clearer, like basal and adluminal, some adluminal missing or something. And then we have something happening here. We'll go on higher power. Don't worry. We're not just sitting there at low power. So we have the main lesion, which we have is not circumscribed, of course. It has an infiltrative edge. Yeah, going here, and it has a bit gland-like lumens. The epithelium is flattened and cuboidal at places, and then we also have this beautiful feature of this thin bridging strands between the tubules. Mostly said in the books, but it does have those. So it's I told you it's a beautiful example. The background was very tricky. I just struggled actually which stage we have reached in spermatogenesis. I couldn't find spermatozoa. Could probably be spermatid level, and all these bigger ones, I think it's probably vacuolated spermatogonia rather than any GCNIs in the background. And because of the meiotic type chromosome, probably these are the spermatocytes. So don't know whether something's going on. So he's a 38-year-old man. Probably we should know something about the background testis in this case. Might be important for him. Oh, and then there was more beautiful things around this case. There was this nerve, and there was one more adjacent nerve which I didn't click. So among the nerve, you can see all these pink cells around the nerve and between the nerve. That's Leydig cells around it, and it's something which some of us have noted and pointed out. People have described the lesion very beautifully, and saw the Leydig cell nodule outside around the nerve. Went on to describe that they don't think it is GCNIS, but atypical spermatogonia. Some are not happy with the terminology used, and they want to change the terminology which is being used. But yes, this is really good. We have got 100% marks. We all got it right. No one got anything wrong. So well done for us. So now, when do we want us to? I mean, I know there was a previous comment about if it's about 90%. Now, if it's 100%, do we want to go through this?
No, just move on. Let's score everyone 1 and move on to the next case.
Oh, great. So that's great. So no scoring, we all get 1. And the next time when it's there, we'll just say we're not doing it. A beautiful article, if people want to go over it, especially because when you have a testicular tumor and you notice this, and if you have not noticed this before, people might panic and think there's a spread outside. So it's a good one. If anyone wants to read. Case number 11, we have a 54-year-old male, 5 muscles and penile warts. We are told there were central warty lesion 9 mm and several smaller warty lesions. So we have 2 pieces of foreskin, something probably looking like normal. And then the rest of the area, we have some papillomatosis, and it looks very thick and very blue. And on the surface, we have some pinky look. We'll go in high power. And okay, there were areas when you can see the bluey bits are a bit lower, but probably it still has an intact basement membrane. This is a bit more lower, but probably cross-cutting artifact. On a bit more higher power, we can see the hyperparakeratosis, full thickness atypia, a lot of mitosis. They're just everywhere, going everywhere to the top. And the red blood cells here, they look biconcave and disc-shaped again. Just enjoying the red blood cells, better one. Again, we saw in the low power, people wanted to do levels to get it better. Yeah, more than 100 of us wanted immunohistochemistry, quite understandable. So people described the lesion, said they needed P16, and morphologically they think it is HPV associated, and wanted levels. So these were the most of the written comments went by. So I did try to contact the original submitting pathologist, but unfortunately they have retired, and so I can't give you the answer what the P16 is. So and Dr. Oxley rightly pointed out there's recent evidence which shows that bacilloid type can also be HPV negative. So without that P16, we have to combine all 3 of them and put that as one. So I hope everyone's listening. We should combine all 3 of it because of the recent evidence, because we don't have any P16. Individually, it will not score. Verrucous carcinoma and squamous cell carcinoma, usual type, bit of an overcall, and dysplasia falling short of PI and is probably an undercall. So should we go ahead? Got locked out. Great, wonderful. So we all think it's scoreable. And let's go back to our voting tabs.
Apologies, Sona, for earlier on. I think the Estates Department took issue with that chromophobe case, I think, and cut the power to the histopath department. So sorry about that. You're on mute, sorry, Sona.
Okay, I don't know where I pressed mute. Okay, so we have HPV status unknown 1, HPV associated 1, oh, HPV independent 1. Really good, thank you so much. And varicose 0, squamous cell carcinoma usual type 0, dysplasia falling short 0. Wonderful. So we move on. Oh, yes, I have put more references to the phenyl just because that's my weak area. We don't have much phenyl stuff, and I think the Norwich guys have it, so we send everything to Norwich for phenyl stuff. We have a good article from Dr. Oxley. It's quite useful actually. It covers all the EQA cases. So this is the one which I was talking about, the HPV negative phenyl intraepithelial neoplasia. This was recently told in the skin EQA. You might have already have this who attend the skin one. Maybe it's useful for gynae also. So moving very quickly from the penile area, before any questions come, to age 12, 45-year-old man, mass in the dome of bladder, we're given a partial cystectomy. They're trying to point a central mucoid mass, predominantly in the bladder wall. No immunohistochemistry is provided. So this is the section which we are provided with. We have a lesion coming from under the epithelium all the way reaching up to the serosel surface. So there is a sharp demarcation. And by eye of faith, we'll say it's probably predominantly centered in the muscle. That's probably inked margin, so margin for partial cystectomy excision. Away from that margin, we'll go a bit more closer. It was all mucin, probably. And then we can see it is pushing towards the surface, but not breaching it, probably. And the epithelium appears non-dysplastic towards the serosel surface. Oh, there was no urachal remnant. It was no cyst formation also, forgot to say that. There's no breach of the serosel area. Yeah, there was a lot of comments, immunohistochemistry required, further blocks, and yeah, in retrospect, probably this was not a good option to select. The drop-down menu was also not, probably we need to sort that out also because people wanted to call urachal mucinous adenocarcinoma and the options available were urachal carcinoma NOS on urachal mucinous cyst adenocarcinoma. So it was not cystic, but that was option available. So people did select that, and people give a nice description of the lesion. And some immunohistochemistry request. Most frequent flyer was beta catenin, and yeah, agree. Several option would fit. So I don't know. Do we want to mark it or just combine all of it? Because in a way, they are all trying to say the same thing.
I guess number 6 is a bit ambiguous. Do you think?
But they probably might be meaning metastatic tumor from the gastrointestinal tract, which can't be excluded. So, and again, mucinous adenocarcinoma, though there was not a cyst, but we don't have an option of mucinous adenocarcinoma. So, I don't know how. Let's see how generous we are feeling, or whether we want to score at all.
Yeah, I don't think it was metastatic, but yeah, that was one person, wasn't it? Yeah, but well, let's see what the public vote is.
Yeah, I think probably we'll all maybe let's see whether it's scoreable first. If you say it's no, then we don't have to worry about scoring. Probably it's all our mistake, this one. Oh yeah, we want to score it. Let's see. So should we go to scoring? Almost there. Oh, voting is stuck at 92, probably. Yes. So we have mucinous adenocarcinoma mucinous type 1, uracil 1, mucinous adenocarcinoma 1, NOS 1, 0.5 adenocarcinoma mixed, metastatic tumor 0. Okay, great. Thank you so much. Just a recent update of the glandular lesions in March 2024 by Paneer and Rees group. I put a table, so if anyone's interested, there was, I mean, it's, we also had a glandular lesions talk by Dr. Meyer and Dr. Chandra some time back. So if anyone has not yet joined the BAUP Wednesday meeting, please make sure you join. It's quite useful, very practical solutions. With that, I'll pass on the baton to John. A familiar face coming up, a relaxing time for everyone. Thank you.
Thanks, everyone. Good afternoon. I'm just going to cover the prostate cases. I'm aware we've been online for an hour and a half, so we're trying. I don't think there's any controversial things particularly in here. So the first case I've got AH13. It's 2 needle biopsies from a 68-year-old gentleman with quite an elevated PSA of 17 and a Pyrodes 4 area on MRI scan. And oops, sorry. So this is representative really of both cores. I take it for this area here. There's a core of glandular tissue with looks like an inflammatory infiltrate that's centric around glands and ducts. Some more free-floating inflammation at the top there. This is the kind of higher power that shows some of this inflammation around and within ducts. There were some slightly paler glands, which I've taken a picture of, which I think some of the comments that we'll come to are directed towards. These were the kind of the most, I suppose, pale, simple, kind of free-floating glands that you may have a closer look at. They don't appear to have any nucleoli, however, and otherwise they look pretty else unremarkable. Again, there's some inflammation associated with these glands that may well be budding off this ductular structure over here. This is another couple of glands in the same core that was further down, which again, I think some people picked up in the comments. Looks like there's a bilayer there, although that's not often a particularly reliable thing to see on a prostate biopsy. But again, nothing else particularly atypical about those glands, certainly no nucleoli, amphiphilic cytoplasm, etc. So there were some comments. I suspect the immunohistochemistry was related to those glands that people suspected could potentially be an atypical area within the glandular structures within that biopsy. Otherwise, there was not particularly any comments generally. And again, most of the comments, there were 98 in total, so a moderate number compared to some of the higher numbers that we've seen in the other cases, that suggested a couple of atypical foci, more levels. Most people thought it was chronic inflammation prostatitis with some atrophy. PIM4 to confirm that it was just inflammation. Needs immunohistochemistry for those particularly couple of those smaller areas which I've shown you. Having noted those comments, over and approaching 94% of us would have called it benign. The next highest at 5.2% was considering a diagnosis of ASAP, which relates to those 40-odd comments of wanting to do immunohistochemistry. There was a couple of people that thought high-grade PIN, and a couple of would have called it adenocarcinoma outright. And it's probably a non-scoring trainee AIP, which is where it says 0. So this was originally diagnosed as negative for malignancy, with 93.4% of us would agree with that. So if we could indicate whether we think that's scoreable with a 93% consensus. Just wait for it to get up to the kind of 80 mark, as we've been doing that for other cases. Okie dokie. So 99% of us would like to score the case. Okay, let's go on and score it. And we're approaching 100. Just give it a couple more seconds for us to get. Okay, we're pretty close. So 99% of us, 0.5 for benign, it's because this had a supplementary question with it. 0 for ASAP, 0 for high-grade PIN, 0 for adenocarcinoma.
These were so these were the actual scores for the AH13. Okay, can you see that, John?
Yep.
Yep. So then the next supplementary question. So the vast majority, again, who obviously scored it as benign, said not applicable for Gleason score. But again, as you see, 6 people have tried to Gleason score. One thought it was very high grade. So shall we try and score this? So it should be eminently scoreable. We'll crack on. It says 60 people. Yep. And then if you go back to your phones and not applicable, again, they're divided into 0, 0.25 and 0.5. I think we can score this. This is fairly straightforward. So not applicable, 0.5. And then we should have, oops. Gleason score of 1 as 0. Grade to group 2, 0 again. And grade group 5, definitely 0. Okay. So, shall I stop sharing, John?
No, because I can't share. So I just talked
okay.
through this. So we're using another AI program for these prostate cores. This is iForia. This is also CE marked. So one of the 3 systems that are CE marked, which are available in this country. So we very kindly ran it through these, and then if you show the next slide, it gives you this detail on it. Gives you the length of the benign tissue, which it's marking in blue, and it called this one benign. It gives you the length of the core as well, somewhere.
Yep.
In all sections 29. So if you wanted to do the whole length cores, and you can see that it's not marked the little bit of tail of one of the cores. It only marks prostatic tissue. So the extra prostatic tissue, it's not measuring in the length of the core over there, which is you might or might not want. If you wanted to do an audit, it might be quite useful to give that information. And that's basically it. So the first one, AH13, is benign.
Okay, good. Shall I crack on? I don't know if John's back. I can't see him on the list. No. Happy for me to carry on? Yeah. So
Go for it.
AH14, the second prostate question, is a 75-year-old man, transperineal prostate biopsy, quite high PSA, 19.4, T2 on DRE, and then a PIRADS 5 located the right posterior. So, so what we have, it's quite a good length core with quite clearly at low power invasive prostate adenocarcinoma. I can see John connecting, and high power, you've clearly got cytomorphological features of prostate adenocarcinoma. It looks as if this small cribriform architecture of these glands here. And then elsewhere, there's individual glands that you could draw easily around them, so more pattern 3. So I think what John's describing here is a mixture of pattern 3 and pattern 4. John, do you want to crack on, or I don't want to speak for you?
Can you hear me?
Yes, perfectly.
Sorry. Yeah, it cut me off, and now I've kind of joined. If you're all right controlling the slides,
Sure,
it
sure,
might
I
be the
will.
easiest thing than me trying to get the slide back up. And yes, so this was really exactly. So this was some almost fused glands, although on the gland that's kind of towards the top right, you can still see a bilayer of cells. So not entirely cribriform, but some of them probably are fused and getting on towards cribriform. But it was really to illustrate within that glandular complex that you still have a bilayer of cells, so it isn't one cell layer between those when you're thinking about cribriform glands. Some of them are fused, however, but just to kind of highlight that definition when we're thinking about cribriform based disease. So thanks. You can move on. And again, there are some more poorly formed glands here. Again, you kind of check over levels really to see if any of these were likely joined up, these glands. Most of them appear to be associated with other glands when thinking about cribriform, Gleason pattern 5 disease. And I would think they were poorly formed rather than definite pattern 5 disease within amongst the kind of atypical glands. You can see really nice prominent nucleoli within those glands as well. Thank you. So comments, there were minimal comments. 19 people would want immunohistochemistry, and there was a spattering of the other comments we typically see. Some of the selected, most of the comments, again, the smaller numbers, only 71 within this case, were about the Gleason grading. And there was equivalent kind of amounts between Gleason 3 and 4. And quite a lot of people picked up on that, whether they would call it 3+4 or 4+3. There were comments about that focus, I think, that I showed in the last picture, whether it could possibly be cross-cut 5, or was it just very poorly formed glands. Some comments about cribriform or not cribriform present, and then we discussed that in that picture. And some other comments about whether we do immunohistochemistry to see if some of that was, if all of it was invasive, which could be important in scoring it, particularly if you've got 4+3 and 3+4 on the borderline, whether it's all invasive disease or some of it was introductal. So they were most of the comments. We think about our scores, 94, nearly 95% of us would have called it adenocarcinoma. Actually, all of the diagnostic entities were adenocarcinoma, so we all agreed that there was adenocarcinoma here. And really, some people wondered if there was some introductal or AIP, so atypical intraductal proliferation, admixed with the adenocarcinoma, but 100% of us noted it was adenocarcinoma. The original report was reported out as 4+3. That's probably based on the whole of the case rather than just the one slide that we had. But again, it was diagnosed as adenocarcinoma.
Just so to jump in there with one question that's come up. Somebody's mentioned, if not cribriform 4, then what do we call it?
Well, it's still pattern 4. Yeah. It's just whether that kind of quite strict diagnosis of the cribriform entity, of whether they're closely approximated or typically in a cribriform, and you wouldn't expect that bilayer between them because they could just be two very closely opposed glands. I think there's definitely pattern 4 in that picture that I showed. It was just that those bilayers, thinking about whether you'd call it cribriform, being that is a kind of another adverse diagnostic, prognostic factor independent of the Gleason grading. So that's probably going to be one of the dataset items that's going to come in, whether there's cribriform in that pattern or not.
So all correct, or
well, I think I would say that adenocarcinoma is mentioned in all three of those. So I would suggest that they're merged as one diagnosis, really, because the presence of AIP or IDC in that kind of adenocarcinoma is fairly doesn't have a huge impact particularly.
Okay. So is it scoreable? I think the answer is yes. Is it?
Yes, I think I would have thought so. Hopefully people will agree. Yeah.
So Hopefully everyone's got the questions, sorry, the answers on their phone. Happy to carry on, John?
Yeah, I think
Yeah.
so. We're probably, some people have probably dropped off it being a bit later.
Adenocarcinoma.
No, Matt, so we all agreed with adenocarcinoma being a correct diagnosis. Adenocarcinoma with ARP also gets 0.5, which probably means that adenocarcinoma with IDC also gets 0.5. I think we're there with a 3.
Yeah.
Great. So the Gleason grading, so the supplementary report when there's supplementary question when there's adenocarcinoma is the Gleason grade, to which we usually approach this as we have a preferred Gleason grade, which is normally the one that we have most consensus over, and that would appear to be 3+4 in this case, which is interesting, given that 3+4, 4+3. So that's our preferred diagnosis as a consensus from the EQA. But there's other, what we would probably call acceptable Gleason scores. 4+3, I would suggest, was one of those, because some people already kind of put in the comments that there was fairly equivalent 3+ Gleason pattern 3 and Gleason pattern 4. So I would suggest that would score as 1, really. And then there may be what we would consider kind of unacceptable, for want of a better word. Don't like that word really, but that's kind of which may be Gleason group 1, because there was definite pattern 4 in there, which would have a clinical impact on discussions at the MDT and treatment on the patient, particularly that amount of Gleason pattern 4. So that may be an unacceptable, so that may be considered to be scored 0. Gleason pattern 4 is an interesting one, whether people would accept that to be a kind of a half mark or because it doesn't take into account the 3 that was definitely there. And Gleason grade group 5 is whether you take that to be a little focus of pattern 5 again, when that's kind of a few Gleason groups away from our preferred diagnosis, so that might be more unacceptable. So that's kind of how we consider the Gleason grades. So I think that's probably scoreable, that 75% of us have got a preferred Gleason grade, and then there are some other acceptable grades I would suggest that are there as well.
Scoreable.
We just let that one run.
Yeah.
In case, just make sure people are happy to score the Gleason grade. We've probably got. We're up to the high 80s, so
Yeah,
shall we have a look?
Okay, happy with that.
94%, yeah, for scoreable. Okay, so let's go on and score the grade groups. We're getting up to the kind of the mid 80s, seems to be the top out number at the moment.
Happy with that, John? Yep.
Yeah, it sounds just slowed, doesn't it? Yeah. So 90, so 0 for grade 1, which is high consensus. Grade group 1, sorry. 0.5 for grade group 2. 0.5 for grade group 3. Seems more than sensible. Grade group 4 gets 0. Interesting. And grade group 5, suspect, also gets 0. Thank you very much. Okay, so that finishes off that case. Is John talking to the AI?
Yeah,
Oh,
yeah,
yep.
I'll talk to this.
Here he is.
So we ran this through the I4, and you'll be glad to know that it didn't really agree with us because
No.
its overall Gleason score was 4+5 because it felt there was some pattern 5 there. But if you go on to the next slide, you see it highlights the different grades and different colors. So yellow is 3, orange is 4, and the 5 is highlighted in red. But I mean, this gives you the idea that you can then look at it and say, actually, that's rubbish. I don't think that's pattern 5, and then ignore it. So then if you ignore that, it would score it as probably Gleason pattern 4+3 in the percentage. It gives you the percentages of each in the top left-hand side. So if you go on to the next slide, I think, and then we're just comparing that, you know, they don't look like the particularly pattern 5 in this area. And I go on to the next slide. I think there's possibly, that's it. And then this area here, it's highlighting it as pattern 5, but you can see that it's just a sort of a mishmash of cross-cut glands, which are pattern 4.
Mm-hmm.
So I was pretty happy that you could, if you were using this tool, review the score, the areas that were scored 5, see what they were calling 5, and remove or put on to the overlay and see what it was calling 5, and then adjust your scores accordingly.
Thanks, John. Okay, so the last case of this circulation, and the last prostate is transperineal biopsies from 61-year-old, moderately elevated PSA at 4.9 with a T2 MRI. And we've got, this is the kind of lowest power of these two cores, which look very fragmented. At this level, there doesn't appear to be much glandular tissue, certainly on the left-hand side of the picture. Fragments of what looks like kind of skeletal muscle, extraprostatic tissue. The glandular elements have got highlighted here, which are these quite densely packed glands, but within kind of organoid structures themselves, voluminous cytoplasm, peripherally pushed over pyncnotic nuclei, almost the kind of look of a prominent basement membrane around some of them, where you can certainly draw a pencil line around those glands. And then these ductular structures, which are admixed, really nice example of branching ducts that are probably leading to these glands, this multi-layered of fairly bland eosinophilic cells. So 34 people would like to do some immuno, and then there's a spattering of other answers, but nothing particularly of high numbers. Virtually all of the comments just mentioned, because it wasn't obviously in the drop-down box, that it was benign and everything looked like Cowper's glands. There was quite rightly some comments that if that's all the tissue you had, you'd make a comment in the report there was no prostatic tissue to assess, and therefore there could be prostate cancer elsewhere in the gland, but you didn't have anything to assess. And there was a couple of comments about not being caught out by foamy gland or low-grade adenocarcinoma. I suppose the clue to that was you weren't in some some glandular tissue. There was skeletal muscle, and you had those ducts interspersed as well. But foamy gland carcinoma would be the thing, I suppose, to just think about within a diagnosis of Cowper's glands. So if we have a look at the responses, 97% of us would have called that benign, although 2.2% adenocarcinoma and a spattering of other diagnoses as high-grade PIN, which I don't think there was any particular features of. Adenocarcinoma with AIP as well was noted. So I think with a 97% consensus, we can probably score it, but we'll ask the question.
I think it is scoreable, isn't it? So
Yeah.
shall we?
I think we can move on to scoring it.
I think so.
Okay. Thanks.
We're probably only going to get 60 or 70, do you think?
Yeah, I think we've slowed down the
Yeah.
responses. People have got tired.
Yeah. Gone for the
Okay.
school run.
Yeah, so the benign gets a mark. Adenocarcinoma 0. High grade pin 0. Adenocarcinoma AIP 0. I think the last one was just another, yeah, with AIP 0. Okay, and we wouldn't obviously Gleason score it because it's not applicable. So we don't normally score those sort of supplementary questions. So if we just run, we can just skip past the scoring.
Yep. Okay. Happy, John? I mean, it's
Yeah, I mean it's a
yeah.
benign case, so
Yeah.
it's not applicable, is it? So which, yeah. And I would have thought the rest of them would agree that it's not applicable. Yeah. 2, 0, 3, 0. Yeah.
Okay.
Yep. Okay. And the AI said,
Well, luckily
is that
the
benign?
it was all benign tissue, and you can
Good.
see that it's highlighting the blue is the prostate tissue, and the stuff which it doesn't recognize as prostate tissue, it's not highlighting. So
Oh, okay. Interesting.
so this is a useful thing to test the AI systems on, because other AI systems do not, they see Kappa's glands as cancer.
Okay.
So we have had it in the past with the page system. We demonstrated on the EQA right at the many years ago that it was picking up Kappa's as Gleason 3+3.
Great.
Something to be aware of.
Yeah. Thank you.
Good stuff. Thank you very much for that. Good. Shall I just very briefly cover this?
Yeah.
I mean, hopefully people are happy with the digital format. We'll carry on with this the way of doing the EQA. Obviously, there'll be a November meeting. I don't think the date has gone out to the EQA members yet, but it'll probably be in late November. We'll continue to host on the Oxford and the Leeds website. With the Oxford, it's slightly lighter than the Leeds. The Leeds is quite dark when you look at the slides. But we always show this as an excellent little table, which is on the EQA site. About it's very helpful actually to got a tricky RCC case.
You could just look up the Alt 3-4 and see which one has got that against it, which does make your life a lot easier.
Yeah, very good. And I think, John, have you used the skin EQA, I believe, for...
So yeah, the skin EQA is being hosted on the pathology portal by the RC Path, which we would probably look into, because it does save a bit of cash.
And it's quite user-friendly, I believe you said?
Yeah, they've managed to get it so you can do a direct link from EQA Lite.
Okay. Okay, now we will look in.
So the other thing which has changed since the last circulation, which we should have put on, is the fact that you will no longer be getting letters saying that if you have a poor score in 2 circulations, you'll be getting a notification via email to log on to the EQA Lite system, and it will ask you for a response before you can do the next circulation. So that's a new feature within the thing. So you're no longer getting the envelope in the post. It'll be a direct contact via the EQA Lite. And there was another question on the chat about the RC Path dataset on prostate. I don't want to whet your appetites, but I'm hoping to get it out for consultation over this summer, whilst everyone's on holiday, so that we don't get very many comments. So that is coming out, and hopefully in the next couple of months we'll be going out to consultation, but these things do take a very long time. And that's that.
One quick question. I don't know if you're involved in it, John. John Oxley. When can we expect a new RC Path data set?
I just answered that.
Yeah, but the consultation, do you know how long it takes?
The consultation will be open for probably, I think it's about a month.
Right.
And then if no one makes any comments, then I then have to review the document, or the authors have to review the document and edit it. So last time we got about 150 comments. So that takes about another 3 or 4 months. And then if you add the references, then the college just has to then add the references. So that'll take another 6 months. So, you know, I'm hoping beginning of new year, we'll have a new data set. The ICCR one is probably going to go out to consultation very shortly as well.
Okay, brilliant. Yeah, some of the people really wanted a date, but yeah, no, so it'll take a little while. Good stuff.
A date.
Yeah, I know. And yeah, so acknowledgements. A lot of people in the background that you don't see. Huge thanks for all their hard work, Lauren, EQA Secretary, and Mick at EQA Light, and both Leeds and Oxford. And again, the aphoria is quite interesting. Is that what you're using in Bristol now, John?
No, we're using Page currently as part of the Articulate Pro study.
Oh, okay, great stuff. So what we'll be doing now, just for the EQA members are still on online, we'll be scoring this, preparing the post-meeting report that will go out to the members, and then we'll start the whole process all over again for the next circulation of November.